So the NALA trial is a large randomized phase 3 registration trial that compares neratinib and capecitabine to lapatinib and capecitabine. And the idea is that neratinib, unlike lapatinib, is an irreversible binder to HER1, which is the EGF receptor, HER2, which is the HER2 receptor, and HER4. And because it's irreversible, the idea is that it would bind to the HER2, permanently inactivate it until the receptors regenerate. So it has a longer-term efficacy, theoretically, than lapatinib. We know that lapatinib capecitabine is the current standard of care for a lot of people in the later lines, third, fourth, fifth line. So the idea is potentially, is this any better? Is this irreversible binder any better? So what happened in the NALA trial is that I'm part of the NALA group. We randomized 621 women who had at least 2 anti-HER2 regimens for metastatic disease. A third of those women actually did have pertuzumab and TDM1 together. About 25% or so just had trastuzumab and pertuzumab. Another 30 or 40% just had trastuzumab-based regimens. And about, I think, 10 or 15% had regimens that had included TDM1 at some point. So these women, of which there was a global trial, and these women, of which about, I think, 30 to 40% were de novo metastatic disease because of the global trial, were again randomized to lapatinib at the standard dose with capecitabine at 2,000 milligrams per meter squared a day versus lapatinib at 240 milligrams a day with capecitabine at 1,500 milligrams per meter squared per day. And the reason that it was a lower dose, that had been established in prior trials. So the study had 2 co-primary endpoints. It had the hazard ratio for progression-free survival and the hazard ratio for overall survival. And the hazard ratio for progression-free survival was met. The hazard ratio was 0.076 with a p-value that was, I think, 0.00053 or something like that. It was a significant p-value. That's number one. In terms of overall survival, the p-value was, I think the hazard ratio was about 0.84 or something, 0.88, and the p-value was not significant. It was like 0.02. In terms of the absolute numbers, these trials were very interesting in that, in terms of progression-free survival, the separation of the survival curves occurred late, really almost after the median. And so the trials actually had a pre-specified, what's called restricted means analysis. And what that meant is that we looked at the mean survival as opposed to the median, because when a curve separates late after the median, the median really isn't going to tell you what happened. So you really need to look at the survival over the entire curve. And we restricted it to the mean survival at 24 months because most events occurred before 24 months of follow-up. And so it turns out when you did this restricted means analysis, which again was pre-specified, we didn't go, oh, we didn't see this median, so we changed it. Now, that's a very important thing to understand. This was a pre-specified analysis before we even looked at the data. And it turns out that the difference in means was about 2.2 months. So it was 8.8 months in the neratinib arm versus 6.6 in the lapatinib arm. And that was statistically significant. It was like 0.004 or something like that. So we had that. The restricted mean survival was again about 0.8, but again about 1.8 month difference, but it was not statistically significant. So clearly it met its endpoints. It met the primary endpoint of PFS, so it clearly is a positive trial. The other kind of secondary endpoints from duration of response, the duration of response was 8.5 months in the neratinib arm versus I think about 5.5 months in the neratinib arm. That was statistically significant. But most importantly, again, getting to the initial thing that we had talked about, the incidence of treatment for symptomatic brain metastasis in this trial was 22% of the patients on the neratinib arm versus I think 29% on the lapatinib arm. And what that tells us is that it reduced the incidence of symptomatic brain metastasis and theoretically symptomatic brain progression by about 6-7%. In absolute terms, that's by about 25% in relative terms. And I think that to me is extremely significant. So I think it's a big deal. It's not so much a synergistic effect, it is you're getting the capecitabine in and you're getting the anti-HER2 therapy in with neratinib, and it's staying there because it's an irreversible binder. That's the best way to think about it. It binds to the HER2 tyrosine kinase there, a little bit, the tyrosine kinase domain, and it doesn't get off, where the lapatinib does. It just bounces off. And so again, if the plasma levels are low, if the CSF levels are low, it's simply going to come off, and it can't stick, and it can't irreversibly damage the receptor. And so, it's a more permanent, it gets into the brain and stays, is the best way to think about it.